present topic of discussion is on part 2 of dental caries. So here in this part we will be discussing about histopathology of dental caries, wherein both caries of enamel and dentinal caries we will see, and also we will add about caries activity tests. So now let's look into histopathology of dental caries. So while discussing this histopathology of dental caries, so for the ease of understanding, we will divide this histopathology of dental caries into caries of enamel and dentinal caries or caries of dentin. Why? Because the process of the caries formation in enamel and in dentin is quite different. So we will deal separately. Okay, now let's look into caries of enamel. So here if we see, so enamel caries itself, that is, it is a surface, right? So mostly early lesions will be, so the description of enamel caries will be in relation to the early lesions, and the type of enamel caries what occurs, right? It differs on smooth surfaces and it differs on pits and fissures. Okay, so let's see about smooth surface caries and then we'll see about pit and fissure caries. So if you see smooth surface caries, here usually the smooth surface caries, it occurs below the dental plaque, that is a decalcification will occur beneath the dental plaque, and this decalcification will be in the form of a smooth chalky white area, and this smooth chalky white area is called as white spot, and this mostly occurs near the cervical margin of the tooth. As you can see in this picture, there are a few white spots near the cervical margin of the teeth, right? So those are nothing but these white spots which are smooth surface caries, and that is macroscopic appearance. But if we see under microscope, that is electron microscope or ultra microscopically, what are the changes seen in smooth surface caries is that there will be loss of interrod substance and there will be attenuation of striae of Ritzius. As we know, striae of Ritzius is a type of hypocalcified structure. That means mineral content will be very less. As such, in case of smooth surface caries, there is decalcification is occurring. So because of loss of minerals, this striae of Ritzius, it will start to get highlighted, because of which only attenuation of striae of Ritzius will be there. Along with these, there will be attenuation of perikymata also. So these are the various ultra microscopic pictures, ultra microscopic changes which are seen in case of smooth surface caries. And how does the caries proceeds here in smooth? Usually caries of enamel will be in the form of a triangle or a cone. As you can see in this tooth diagram, there is a red color triangular cone, right? So if you see the triangle where the base of the lesion is towards the surface and the apex is towards the DEJ, that means on the top it will look like a bigger lesion, but whereas when you start to dig deeper, it will end in a point. Okay, that is about smooth surface caries. If we see about pit and fissure caries, here like mostly there is no difference between pit and fissure and smooth surface, just that here the caries will follow the direction of the rods, enamel rods. And if we see the like direction of the caries formation, here also it will be in the form of triangle or cone shaped, but as you can see it is occurring near the pit. But if you see, the apex of the triangle is towards the surface and the base is towards the DEJ. That means here if we open the lesion, okay, it will be deeper towards the DEJ. That means here along the DEJ it will even involve the dentinal tubules resulting in cavitation. So greater number of dentinal tubules are involved resulting in cavitation. So it is kind of opposite to that of smooth surface caries. Next, if we see this triangular zone, that is under light microscope, that is histological zones of enamel caries, there are various zones seen, that is translucent zone, dark zone, body of the lesion and surface zone. Okay, so that is from down to upwards, this is okay. So here this is a picture wherein the translucent zone is towards the DEJ and the surface zone is on the surface of the tooth. So like that these are arranged: translucent zone, dark zone, body of the lesion and surface layer. And how can we see these different zones of enamel caries? We can see them only in ground sections of the teeth, that is thin slices of the teeth, where if they are imbibed with quinoline. So why quinoline is because it has the same refractive index of that of enamel. Okay, and these ground sections, they are viewed both under transmitted light and polarized light. Then we can know the different variations which are seen under each zone. So firstly we will see about translucent zone. Here it is the deepest zone, lies at the advancing front, and most of the times this translucent zone, that is half of the times this is not present. So it is not always present, and as it is a carious lesion, right, so definitely there will be pores in each and every zone. So comparatively here translucent zone, it is more porous, and also the pores are comparatively larger than the normal enamel, and this pore volume is around 1%. And if we observe this translucent zone under transmitted light, it will appear structureless. As such, it is not always present. If it is present also, it will appear structureless, and it contains more fluoride content compared to that of the normal enamel. And next is dark zone, and it is located in between the translucent zone and the body of the lesion. And this dark zone is called as a positive zone. Why? Because this is always present. Okay, and the name itself says it is dark. Why is it a dark zone? Why? Because it is as a result of demineralization. Under ground sections, this zone will appear dark brown in color. That is why it is named as dark zone. And if we observe this dark zone under polarized light, it will show positive birefringence compared to that of the sound enamel. And why positive birefringence will be there is because of the smaller pones which are present compared to that of the translucent zone. And here the pore volume is around 2 to 4%, whereas the pore volume in case of translucent zone, it is 1%. And next is body of the lesion, and this body of the lesion, it is present in between dark zone and the surface zone. Okay, and as you can just compare it in the given picture here, that body of the lesion, on the top there is surface zone and in the bottom there is dark zone, and this is the zone of greatest demineralization. So here demineralization will be so much, and here the pore volume is around 5% at the periphery and 25% at the center. So as I told you, here it is the area of greatest demineralization, that is mineral content is lost. So the stria of ridges will become more prominent, same like we have seen in smooth surface caries, right? The same way. Well marked stria of ridges will be there, and under transmitted light this zone will appear translucent in nature. And same like dark zone, even this shows positive birefringence. And because of the decreased mineral content, why there will be decreased mineral content is because of more and more amount of ingression of bacteria as well as saliva, resulting in this decreased mineral content. And next is surface zone. Surface zone, it is a relatively intact zone. So it is a zone of negative birefringence, whereas the other two, body of the lesion and the dark zone, they are positive birefringence zones. And this zone remains intact and well mineralized. Why? Because they tend to get calcium and phosphate from the saliva. That means the calcium and phosphate used to get reprecipitated on the surface, so resulting in remineralization procedure. So that is why the surface zone will remain intact, only the destruction will be under the subsurface zone. So this is about caries of enamel. Now let's move into caries of dentin or dentinal caries. So why this caries of dentin is different from that of enamel is not vital like that of dentin, and the dentin, as it is a part of dentin pulp complex, it has a tendency to mount a reparative response. So any change, there are this undifferentiated mesenchymal cells which will come into action, and the secondary dentin can be produced. So it reacts. So dentin reacts. So if you see in this picture, caries of enamel is there, that is moving towards the DEJ. Here the DEJ is affected now. So along the DEJ, it starts to laterally spread, and then from the DEJ, the caries will start to spread through the dentinal tubules, and then it will move towards the pulp. So spread will be through the dentinal tubules. So this whole dentinal caries, what we have seen in these three pictures, it is explained in early dentinal changes and advanced dentinal changes. Okay, so what all will be there in early dentinal changes and what all are there in advanced dentinal changes. So if you see in case of early dentinal changes, as you can see in this picture, the old picture, wherein the caries from the enamel along the DEJ and now entering towards the dentinal tubules, and this is a zoomed picture of DEJ with the underlying dentinal tubules, and on top now there is a dentinal caries, the dark spot, and now we will see what all changes, that is what is the response of our dentinal tubules for this caries. So those yellow globules what you see, those are nothing but deposition of fat globules, that is dentinal tubules are undergoing fatty degeneration. Okay, as a response. So after this fatty degeneration, what happens is dentinal sclerosis will happen. Why? Because it our dentin or dentinal tubule, they will try to stop the ingressing microorganisms. So when it is sclerosed, microorganisms cannot move. But if the microorganisms are more virulent, they will start to grow more and more. Okay, resulting in high bacterial invasion like that. As you can see, there are two types of bacteria there, some in green, some in blue, right? So the green ones are nothing but round cocci and blue ones are bacilli. And you can see different types of organisms in the upper portion of dentin and lower portion of dentin. Why? Because like if it is near to the surface, nutrition will be there. As the caries is going deeper, it will be away from the nutritional source. So in the deeper dentinal caries, there will be growth of proteolytic organisms, whereas in the superficial or early dentinal caries, there will be acidogenic organisms. Now this whole early dentinal changes, they are grouped into some zones. That is, first is zone of fatty degeneration as a response. So those fatty globules will appear. Then followed by dentinal sclerosis, that is our reparative response to stop the bacteria from coming inside. So resulting in later on these bacteria will cause some decalcification in that area, but our bacterial invasion is high and their virulence is high, resulting in zone of bacterial invasion. And as the bacterial invasion is there, it will start to eat away the dentin, so resulting in decomposed dentin. So zone of fatty degeneration to zone of decomposed dentin. So these are all early dentinal changes. So now let's see what all changes will be there in advanced dentin, advanced dentinal changes. So here if you see, it's the old picture wherein bacterial invasion resulting in decomposed dentin. Okay, so first thing what happens is it causes decalcification of the dentinal tubules, and what it is showing is those are proteolytic organisms in the deeper dentinal caries, and the superficially those are acidogenic organisms. What acidogenic organisms will do? They do decalcification of the dentinal walls of the dentinal tubules. As you can see, there is no black outline or thinner black outline are there around the bacterial growth. That means that there is decalcification of the walls of the dentinal tubules. So as there is decalcification, what is the dentin which is present around the dentinal tubules? It is peritubular dentin, which is also called as sheath of Neumann. Okay, so as a reparative response, there will be thickening and swelling of sheath of Neumann. That yellow thing what is seen around the microorganism, that is nothing but the sheath of Neumann. So thickening and swelling of sheath of Neumann is seen. Later on, these microorganisms, they will start to release their toxins and products and everything, and results in some necrotic foci. So now here necrotic foci. So this necrotic foci consists of breakdown of these dentinal tubules, decalcification of the surrounding dentin, and with a group of microorganisms. So all this will form an ovoid area of destruction. This ovoid area of destruction is nothing but liquefaction foci of Miller. Liquefaction foci. And as there is dumping of these microorganisms there, it results in increased diameter of the dentinal tubules. Okay. So now decalcification, it is caused by acidogenic organisms. So after decalcification, that is after the mineral content is gone, there will be softened organic material. So that destruction of the organic matrix is done by proteolytic organisms. So this is resulting in destruction of the dentin. Okay, as this destruction of dentin is proceeding forward, it results in areas of necrosis. So as you can see, some dark areas now, those are all nothing but necrotic masses will start to form, resulting in softened dentin. Okay, so this necrotic mass, it causes soft leathery consistency of the dentin. So after the necrotic mass is formed, later some clefts will start to form. That is, this pink areas what you can see, those are nothing but clefts. Okay, as you can see, the cleft's direction is transverse, that is at right angles to that of the dentinal tubules, and also at right angles towards the incremental lines of dentin. Okay. So these are nothing but transverse clefts which are seen along the necrotic masses. As you can see, all this softened necrotic dentins, that is softened caries, it can be like clinically, if you see that blackish appearance, that is nothing but softened caries which can be excavated by hand instruments. So this is about dentinal caries and altogether about histopathology of dental caries. Now let's move into caries activity tests. So first off, it is lactobacillus colony count test. So here the main principle behind lactobacillus colony count test is that we will measure the number of aciduric bacteria in patient's saliva. Okay, this aciduric bacteria here, it is nothing but lactobacillus bacteria. And the medium, the selective medium what it is used to grow this lactobacillus is tomato peptone agar, which grows at a which is at a pH of 5.5. Okay. So here what we will do is, like on this agar, we will pour the collected patient's saliva and we will incubate it. So now that recent studies have shown that there is one more selective medium to grow lactobacillus, that is rugosa agar medium, which have good acidic pH and high amounts of acetate, salts and lower surface tension, which gives a highly selective nature for the growth of lactobacillus. So either tomato peptone agar we can use or rugosa medium we can use, and we will grow the bacteria. And if we count the colonies, if the colonies are ranging from 0 to 1000 organisms per ml, then there is little or no caries activity. Then 1000 to 5000 slight, whereas 5000 to 10,000 moderate amount of caries activity. If it is more than 10,000, then there is marked amount of caries activity. Okay, so this is about lactobacillus colony count test. Next we will see about calorimetric Snyder's test. This was developed by Snyder in 1951. So here we will be estimating the amount of acid produced in the patient's saliva. So when we determine the amount of acid produced, we will get to know like how much amount of caries activity is there in particular patient's mouth. So here what we will see, ability of salivary microorganisms to form acid from a carbohydrate medium. So to determine that pH in the medium, we will use an indicator called as bromocresol green. Usually this bromocresol green will be at a pH of 4.7 to 5, and this will act as a color indicator. Okay, as you can here there is a picture now of various test tubes of different patients. As you can see, the color variation, it is from blue to green to yellow. Okay, this change in colors is depends upon the amount of acid produced in each patient's saliva. So when the blue to green is seen, when the patient's saliva's pH is around 4.7 to 5, that is acid produced in them is 4.7 to 5, and if the pH is around 4, then it shows yellow color. So like if you see here, if you start to predict the caries activity, if the patient's saliva shows yellow color in the first 24 hours, then there is marked caries activity. Okay, then you don't need to repeat the test also. But if it is showing yellow after 48 hours, then there is definite caries activity. If it is showing yellow color after 72 hours, then there is limited caries activity. Same way, if the color is green in the first 24 hours, then we can continue the test. If it is same green even after 48 hours, then we can continue the test. But if it is still green in color after 72 hours also, then it is inactive caries activity. So that means like patients his saliva doesn't have the high tendency for caries formation. Okay, that is about Snyder's test. Next we'll see about swab test. Swab test, it is very much similar to Snyder's test, and here also we will be using a color indicator to determine the aciduric and acidogenic elements of the oral flora. But how is it different from Snyder's test? It is Snyder's test, we will use saliva sample, right? Whereas here in case of swab test, here we will take a swab of buccal surface of the teeth. Okay, using a cotton applicator, and this swabs, they are incubated in the medium. Okay, and this medium, like we will incubate it for 48 hours. Okay, and this is read by a pH meter for the color change. So after 48-hour incubation, so if we see the color change, okay, so like same like how we have seen with the bromocresol green, same way. So if the pH of 4.1 and below it is there, then there is marked caries activity. If the pH is around 4.2 to 4.4, then it is active. Then if the pH is 4.5 to 4.6, then it is slightly active. And if it is 4.6 and above, that is more than 4.6, then it is considered as inactive caries lesion. This is about swab test. Next we will see about salivary Streptococcus mutans level test. So here in salivary Streptococcus mutans test, the main principle is that we will count the number of Streptococcus mutans forming colony forming units per unit ml of saliva. It is somewhat similar to that of lactobacillus colony count test only, where we will be counting the number of colonies which are present in that patient's saliva. Okay, and here the medium what we use is Mitis salivarius agar, which is very much selective for Streptococcus mutans. Why? Because it contains high amount of sucrose and bacitracin in 0.2 units. So bacitracin actually it suppresses all other bacteria other than Streptococcus mutans. So when we incubate it and see if the colony count is greater than 10 power 5, then the patient is having acceptable caries activity. So anything above 10 power 5 colony forming units of Streptococcus mutans, then caries activity is very high. Next is Streptococcus mutans dip slide method. So here what we do is like we will collect dip slide, right? So same way it will be like see, we will collect stimulated saliva from the patient. It is for 5 minutes we will collect, and then it is poured over agar coated slide. Okay, so and then we will pour it until the total surface is wet, and then we will drain off the excess, and then we will allow it to dry for some 10 minutes. So after the slides are really dry, on the slide we will place bacitracin discs, okay, which are 1 centimeter apart. As I told you earlier, bacitracin allows the growth of Streptococcus mutans, but it doesn't allow the growth of any other bacteria. Okay, and this bacitracin disc placed the slide which is coated with the patient's saliva. Okay, that slide, it is placed in a tube containing carbon dioxide tablet, and it is incubated for around 48 hours. So what we will see is that a zone of inhibition of around 10 to 20 mm, it is formed around the bacitracin disc, because this bacitracin inhibits the growth of bacteria. So zone of inhibition is seen around the bacitracin disc, and remaining all other area there will be growth of other bacteria. But if at all if the patient's saliva is containing Streptococcus mutans, then in this zone of inhibition we will see small blue colonies, which indicates that the patient's saliva contains Streptococcus mutans, because bacitracin allows the growth of Streptococcus mutans. So this is about Streptococcus mutans dip slide method. And next and last caries activity test, it is salivary reductase test. So here we will measure the activity of reductase enzyme which is present in the salivary bacteria. So here the incubator and the indicator what we use is diazoresorcinol, where here it changes the color from blue to red to colorless or whitish on reduction by mixed salivary flora. Okay, so the activity of the reductase enzyme is measured by the color of the sample. Okay, so if we see blue color in the first 15 minutes, then it is non-conducive to caries activity, and then orchid color in the first 15 minutes, then it is slightly conducive. Red color in first 15 minutes, moderately conducive, and if we see red color immediately, it is highly conducive, and if it is showing pink or white color immediately, then it is extremely conducive. Okay, so this is about salivary reductase activity, the reductase test. So this is about dental caries in detail, where in this present topic we have seen about histopathology of dental caries, where we have divided into enamel caries and dentinal caries. So in the exam point of view, both the zones of enamel caries and the zones of dentinal caries is very much important, and even various types of caries activity tests can be asked. And in the first part we have seen different theories of dental caries and etiology of dental caries, etiological factors and factors promoting dental caries is been discussed. So most of it like not as an essay but as short notes, this whole dental caries is important.